last time I did this talk, it was about a year and a half ago when I first started here and didn't know as many people. And so it's really nice to see some familiar faces and names. And so I feel like I'm among friends when giving this talk. So I will share my screen and then I think everything is already set up and ready to go. Everyone can see this okay?
Yep, looks good, Kate.
All right, so I know that we had a kind of an ambiguous title, which was research updates from myself, but I actually am going to be a little bit more specific and talking about a hopefully soon to be awarded grant on addressing brain injury among individuals who are unhoused. So before I get into specifics of my talk, I'm going to briefly introduce myself. At least I'm not wearing the exact same outfit, but pretty close. This picture here, which I just pulled from the internet. But as Kedar said, I'm Dr. Kathryn Hyzak, and I'm a relatively new faculty member in the Department of Physical Medicine and Rehabilitation in the College of Medicine at The Ohio State University. And I have several faculty affiliate appointments also across the university. One is Catalyst. It is the longest acronym ever. So it's essentially for faculty member who are doing health services and implementation research, also a faculty affiliate in the College of Public Health, and of course here in chronic brain injury. So I am an implementation scientist in my training, and I actually completed my PhD here at in the Ohio State University and focused my area in implementation science and specifically in traumatic brain injury rehabilitation. So that is how I kind of identify as a professional. And I think I just have my email at the end here. I think I took away my personal website, but we'll see at the end. And if not, we can share it so that you can learn a little bit more about my work. So today's agenda, we're going to set the stage and talk about a brief overview of what this National Institutes of Health, or NIH, R34 grant is and what that even means, since it's a different kind of a mechanism than typical. I'm going to define housing instability and homelessness so that we understand what the difference is. And then I'm going to discuss brain injury and homelessness as a wicked problem. And then we're going to discuss neurologic informed care, which is really what we want to achieve in the homeless and housing service setting. And then I will talk about the aims of our R34 grant in a little bit more detail to give you an idea of what we plan to do. Okay, so the title of our grant is Neurologic Informed Care to Improve Health Equity Among Persons with Brain Injury Experiencing Homelessness, a Community Engaged Implementation Approach. I love my long titles, I guess. So if anybody has a nice cutesy acronym that they can plug in here, we are still on the market for that because I have not come up with anything good. So this is the title of our project. So we have a really stellar rock star investigative team. So this is a dual principal investigator grant with myself, who's the contact of the grant, and then Dr. Jenny Bogner, who I think many of you have heard of or know. And then our co-investigative team here consisting of Dr. John Corrigan, this first individual here, I'll put my cursor over it, and then Caitlin Sinovec, who, oh, by the way, I think everyone knows John, but I just assumed. So John is one of our colleagues in physical medicine and rehab, and as a senior person at the university. And then Caitlin Sinovec is at the National Healthcare for the Homeless Council, who is an occupational therapist by training, but has extensive experience in doing frontline work in homeless and housing service centers, specifically for individuals with brain injury. And then we have Dr. Natasha Sleznik, who is the Dean of Research and professor in the College of Education and Human Ecology, whose research focuses in homelessness. So I think, honestly, our investigative team was a real push for why we got this grant. I think the grant was really solid, but our investigative team is really stellar. So I feel fortunate to work with everybody. Okay, so how did this project even develop, and what is some background? So about 2 years ago, the NIH issued a brand new call for proposals on community engaged health equity research in neuroscience initiative. Specifically, they issued what is called an R34 funding mechanism. And I know this is like really technical language, but it's important, I think, to understand based on the scope of and size of the study. So they issued this through the National Institute of Neurologic Disorders and Stroke because they really wanted us to start thinking about those of us in rehabilitation and neurologic disorders to start thinking about health equity when we come to the treatment of individuals with different neurologic disorders, whether that's brain injury, acquired brain injury, traumatic brain injuries, multiple sclerosis, Alzheimer's disease, things like that. And of course, our team are experts in traumatic brain injury, so that's what we wanted to focus on. So an R34 mechanism is a research-focused planning grant aimed to lay the groundwork for a future clinical trial. It is 3 years in time, so that is not a ton of time, but the goal again is to really lay the groundwork for a future clinical trial, everything that you need to gather, all the feasibility data, the pilot data, the planning that goes into conducting a big clinical trial in the future. So in this announcement, they specifically wanted us to assess the feasibility and or determine best practices to conduct community-engaged health equity research in neurological disorders with populations who experience health disparities. And here is where we thought this was a great opportunity to start to focus on a population that has been, I think, very neglected in the research literature, which is individuals who are unhoused and who also have a traumatic brain injury. So lots of literature, of course, in brain injury, lots of literature in the homelessness space, very, very little literature in the United States on brain injury and homeless together. So we wanted to focus on this. The other thing that we loved about this is the community engaged approach. So and I'll talk on my next slide about this, but we went to pretty great extent to include different members of the community in the planning of the grant, in the writing of the grant, and they will be involved throughout the duration of the grant as well. So this had some special requirements, which I talked about briefly, but they wanted in the grant for us to include research with persons who actually have lived experience of the condition. So individuals with homelessness who are homeless or experiencing housing instability and brain injury in our case. They wanted a plan for enhancing diverse perspectives. So those are historically underrepresented individuals in the research, women, organizations who are typically left out because they're under-resourced. So for example, community-based housing and homeless service organizations are much less resourced than a place like the Ohio State Medical Center. So the nature of the research is going to look a lot different in these settings than in a well-resourced organization. So what we did first to help plan for writing the grant was convene a work group on brain injury, homelessness, and housing supports. And all of these symbols here represent the different organizations that we engaged, at least one individual from each of these organizations, to participate in a series of co-learning activities over the course of a year. So we met for once a month for 1 hour to co-learn about brain injury, where we shared information on brain injury to our housing partners, and they shared much more information for us on what housing instability means and what homelessness actually means. So my expertise is more in brain injury and not at all in homelessness. And so I had a lot to learn over the course of that year and while writing the grant. And that's what I'm going to present some of today. Okay, so what does it mean to be unhoused? So by definition, according to the U.S. Department of Housing and Urban Development, housing instability is defined as spending more than half of one's income on housing, moving frequently, or living in overcrowded conditions, or living with friends or family members. So that's housing instability. Contrast with that is homelessness. Homelessness is defined as lacking a fixed, regular, adequate nighttime residence. So nighttime residence. So this could include any kind of public or public setting like a campground or abandoned building or a car or a nighttime residence that is not used or designed for sleeping, whatever that might look like, a park bench. Living in a publicly funded shelter, considered homelessness, or an impending loss of housing. And that is specifically where there is nowhere to go in the next 2 weeks. Maybe you are in unable to pay rent and you are getting evicted, and that is considered homelessness already. And then finally, or also unaccompanied youth under the years of 25 or younger. And finally, individuals who are fleeing domestic violence are also considered homeless rather than having housing instability. Okay, want to talk about wicked problems. And specifically, this is where I think when you compound housing instability or homelessness and brain injury, you have a very wicked problem. Who here has heard this term before? You can either just unmute yourself or just try to raise your hand. I see some hands raised, and it's understandable some of you are off camera. So when I presented this last, I know at least one of you has already heard this talk before, but no one in the room raised their hand at that time. And that was kind of surprising to me. But wicked problem is a social or cultural phenomena that are very difficult or impossible to solve and has no one right solution. There are no set number of solutions and no formula for solving the problem. There are no trial or error of solving the problem, since every attempt counts toward solving that problem. And finally, every wicked problem is a symptom of another problem. So think about this. When you think about a wicked problem in the context of brain injury and homelessness, that they compound on each other, which I will talk about here. So about 50% of individuals who are unhoused have sustained at least one brain injury in their lifetime. TBI is approximately 14 times higher in the homeless population than in the general population, which is quite significant. And we know that at least half, but up to 90% of individuals sustained their brain injury prior to becoming homeless. So we know that with some of the symptoms of brain injury, whether that is impulsivity, difficulty maintaining social relationships, difficulty maintaining healthcare, because unfortunately in the United States, healthcare is tied to having a job. So being unable to sustain or hold down a job would precipitate or result from brain injury and often precipitate becoming homeless for all of these reasons. So thinking about that wicked problem where there is no one right answer and every wicked problem is a symptom of another. We know that cognitive behavioral impairments that follow brain injury can contribute to the chronicity of brain injury. And this is further compounded by socioeconomic disadvantage, as I talked about unemployment, and again, related to a lack of insurance, since that is often tied to having employment, or individuals who are of other vulnerable backgrounds, LGBTQIA+, I think of specifically, and a lot of the violence that they tend to experience can really compound some of the socioeconomic disadvantage for those populations. Persons of color, women, and those who are geographically rural who may not have easy access to healthcare or other social service supports. So we know also that currently housing and homeless service programs are not well equipped to address the needs of individuals who have a brain injury. Specifically, staff do not always have enough knowledge or understanding about brain injury to know how to address individuals who come in seeking treatment for or seeking help for obtaining housing and might be experiencing some of those cognitive and behavioral issues and not know how to address them or not realize that they might be related to having a brain injury. Impairments can be subtle, often resulting in a person being labeled as not motivated. So one of our work group members specifically talked about this. He said to us that he would go into his case manager would give him paperwork to fill out, and he had difficulty filling it out just because of the difficulty with task initiation. And the case managers did not understand why he just could not fill out his paperwork. And it goes with being called unmotivated. They don't want to change. They don't want help, which just isn't true. It's just a symptom of brain injury. On top of that, housing
Excuse me,
support is...
I'd like to point something out that you have not even considered in this presentation. It's not just brain injury. It can also be a physical disability that came from the brain injury, or the injury could have happened The disability can be before the brain injury, which adds another whole layer to the problem.
Absolutely. I think that's such a great point, and I'm happy you brought it up because I didn't say it specifically, but I think there's a few things that you said there is like the physical disability is another aspect that is sometimes can be more apparent to the eye than some of these more hidden disabilities, which are associated with cognition or behavior, and absolutely can contribute to some of the problem.
Well, it can go the other way too. They see my
Yes.
physical disability, but they do not recognize my brain injury.
Right. Yes, exactly. And that's a really great point. So I appreciate you bringing that up and bringing that to our attention, definitely. Um, so I think continuing with some of the problems, in addition to what Melody brought up here, is what housing programs do exist right now are less effective at improving the well-being for those who do have a traumatic brain injury or any other form of brain injury. So those initiatives we know are not tailored or adapted to individuals with brain injury, and those individuals tend to not do as well in some of these current initiatives meant for more of the general population. So I talked in my agenda, at least, and it was mentioned in the title of the project, about neurologic informed care. And this is what we hope to achieve eventually. And we want to get integrated and implemented into housing and homeless service organizations. So essentially, neurologic informed care is an approach to providing services that takes into account an individual's unique needs of the person who has brain injury. It is a very simple and scalable model of care, and you can think of it as parallel to trauma-informed care. I think Dr. Corrigan might have given a talk on neurologic-informed care, perhaps not for this group, but we should consider it for the NeuroNights at one point. But if we were to break it down into components of what neurologic-informed care means, since it's an ambiguous term, if we were to break it down into intervention components, it's essentially screening for brain injury. That doesn't just include traumatic brain injury, but other forms where a brain injury might be resulting from. So anoxic brain injury, where you lose oxygen, or hypoxic brain injury, also losing oxygen, just or complete cutoff of oxygen from strangulation, for instance, or perhaps an overdose, or other forms such as like through a stroke. In addition, screening for cognitive and behavioral impairments, so those invisible things that people may not be able to outwardly see, being able to recognize that these are impairments that an individual with brain injury might face. And then finally, accommodations that are integrated into services. So essentially, these are pretty simple and scalable interventions that can be used in these settings. They're just not being used yet. We hope that by integrating neurologic informed care, our anticipated outcomes would be improved client-provider interactions, enhanced client self-efficacy as the result of those improved client interaction with their caseworker, which would then result in improved client service engagement and improved housing access and greater retention in housing services. So not losing the housing after they've obtained it. With all of this, however, having a good intervention does not mean that it actually is going to get used in the real world. The traditional research pipeline paradigms often focus on testing the intervention for efficacy and then moving if it's effective, and then thinking about implementation years or decades down the line. And this can often result in slow or no use of an intervention, meaning that the clients who we hope to receive it aren't actually getting it. Also, as we move through that research translation pipeline, interventions often tend to lose their effectiveness when they move from efficacy testing through implementation. And we sometimes refer to this as a voltage drop. So they not only lose their effectiveness, but they also aren't getting used at all. So you have these great interventions that nobody is using, and therefore clients are not being able to benefit from. So finally, the final point I want to make here is that implementation of the intervention, not just the intervention itself, but implementation of it is often inequitable. So I talked previously about highly resourced organizations versus less resource organizations, what you will be able to do and achieve in a medical setting that is well resourced is very different than what you're going to be able to achieve in a less resource setting like a homeless or housing service setting who doesn't have as much money as a giant academic medical center. So we really want to look at how we can make implementation equitable. So in other words, not giving an organization an impossible task related to implementation that they would never be able to do. So for example, changing electronic health records, like, okay, well, we know those work, but they don't even exist in these homeless and housing service settings. So we wouldn't suggest that to be something that they do because it's not going to be an equitable way to implement an intervention. So we don't want to just focus on equitability of the intervention, but also the implementation of it. Which leads me here to the overview of my project aims. And sorry, I'm like talking a lot, which is causing me to cough. Okay, hopefully that doesn't happen too much more. Okay, so this is along the community engagement partnership continuum when I talk about my aims. So again, community partners are going to be highly engaged throughout each stage of this process. So in aim 1, we want to determine the acceptability of neurologic informed care. I'm just putting NIC here for short, and what adaptations might be needed so that it can fit to the service context. Number 2, assess factors that might affect the adoption of neurologic informed care. And then finally, we want to develop a blueprint that can help us implement neurologic informed care in the clinical trial and in the future clinical trial. Okay, lots of puts. All right, so for aim 1, specifically what I just said was we want to determine staff and client level acceptability of neurologic informed care and if adaptations are needed. This is important because right now, neurologic informed care has really been codified by the American Society of Addiction Medicine to use in substance use treatment organizations, but it is not something that's specific to substance use disorder. However, right now, that's kind of the oriented thinking around it. So we'd want to see if something needs to be adapted to fit the homeless and service population or those who are unhoused. We're going to do this by actually talking with clients in these homeless settings. So we identified a medical care setting in Cincinnati who's willing to work with us to let us come in and actually do interviews with clients to talk to them about what they think about neurologic informed care as an intervention. If they think adaptations are needed, like what would help them to engage in the intervention? Would they like their provider to do the brain injury screen with them? Or would they prefer a more private setting where they did the screener on their own? Or what type of accommodations do they think would actually be beneficial for them to use in the service setting? And when they leave the service setting, what would that look like? And then also, what are some barriers to participating in neurologic informed care? Are there trust issues with the healthcare system that would affect them wanting to disclose having a brain injury? Do they have health literacy enough to know what a brain injury is? And to what extent do we also need to educate them on a brain injury so that they can understand what it means and want to engage in this kind of an intervention? We'll also do focus groups with 40 staff who also work at the setting and who contract with the setting because we also want to understand their perceptions and advantages of actually using neurologic informed care with their clients and how they can best engage clients to participate in this intervention. So these results will be taken, I realize I did not define this, to our Community Advisory Board, or our CAB, and that's our stakeholder board of those groups of symbols you saw earlier, those images you saw. And we will take it to them, all these results, to have them adapt and further refine neurologic informed care. Okay, aim 2, we want to investigate the contextual determinants to the uptake of neurologic informed care across homeless and housing service programs. So this slide is a little bit technical and I'll walk us through it. So we want to use a mixed methods design. So specifically, you can see here where I've emphasized quant, which stands for quantitative, and qual, which stands for qualitative, because we will do quantitative surveys at the same time that we do interviews. So we want to understand with this, the multi-level factors that affect the uptake or the adoption of neurologic informed care. So we're going to do this. So quantitative, the quant part of it, we're going to issue 100 surveys out to staff. So we want staff members, 100 staff members from across the country to take surveys to assess their readiness for implementing neurologic informed care, which would include their commitment to change and their ability to actually change, to do the change. We also want to understand the extent to which organizations collaborate with each other to deliver high quality care. I mean, the people are not hopefully going to be in a homeless shelter forever. They are going to have to work together with health service settings or more permanent placement settings to get the individual the other care that they need. This will require cross-system collaboration, cross-organizational collaboration. We want to know the extent to which these organizations are doing that now. By learning these types of things, we can then use this to understand what strategies we might need to put in place in our implementation blueprint to improve some of these problems. Okay, so for the qualitative part, the qualitative data stream, we are also going to interview completely separate 25 staff that we identify from across the country. So we really want variability in geographic region, so that we can understand what skills and expertise they think that they need in order to deliver neurologic informed care with high quality, how easy they think it is to use, if it's intuitive to use, if they think that there are benefits to the clients, what level of leadership support they have, if there are any incentives for them to deliver neurologic informed care and what those incentives might look like, and if they personally have any stigma or discriminatory ideas or thoughts that we might need to provide education to combat so that they can deliver neurologic informed care equitably. All right, our final aim, and I think one of my final slides here so that I can get to questions, is we want to use all of this information from our first two aims to co-develop what we are calling a neurologic informed care implementation blueprint alongside individuals who actually have lived experience and community partners. So an implementation blueprint is not a new concept, but it is an implementation, multifaceted implementation strategy set. So essentially it includes a grouping of implementation strategies that are meant to overcome barriers to adoption of an evidence-based intervention. So like I said, what we're going to do is present to our community advisory board the results from AIM 2 and ask them to prioritize those barriers that we found out from the surveys and those qualitative interviews. Specifically want them to rank order. So there's going to be a lot of barriers. Okay, we can't solve everything all at once. So what we want them to do is to rank order the feasibility of addressing each barrier and then the level of importance. And this is what's getting at the equitability of the implementation side of it, not just the intervention. So what can you feasibly do to address these barriers now? And what is the most important to address? So we're going to have them identify, I think we said the top 10, and there will be way more than 10. We just want to prioritize barriers to address. So we will then identify from here an initial set of implementation strategies through an implementation strategy barrier mapping process that I've used before in some of my work to identify an initial set of strategies that we might include in our blueprint. And the strategies that have the highest feasibility and adherence to the impact of our intervention will be retained. So essentially with our CAB, we'll work together to figure out, okay, what barriers do we need to address right now? What can we feasibly address? And then from the strategies that go into our blueprint, what has the highest feasibility of addressing these strategies and what can we do to make the greatest impact through using these strategies? So we will finalize that blueprint and with our community advisory board, and that will be used as our core thing, essentially, that drives implementation in the big clinical trial that will hopefully come from this work. Okay, so I did a pretty good job on my presentation, actually much shorter than I thought. And so I can be emailed here. I wish I put my page here instead so you could read, but I'm going to stop share and then we can do a Q&A and discussion. And I'm sure there's lots of thoughts that everyone has doing here.
Awesome. Thank you, Dr. Hyzak. So if you have questions, you can unmute, you can throw them into the chat, and I can read them out. I think, Paul, you were raising your hand, so feel free.
Yeah, thank you, Kathryn. Hi, nice to see you again.
Nice to see you.
Um, so just a couple of questions, actually. One, you made upfront reference to the use of people with lived experience. Not only, and my question really is, and that's obvious in terms of the importance in gathering research work and understanding what you're dealing with, but also in the messaging of this, not only to advisory boards, but also securing the grant. And I'm just kind of curious what your thought is or how you've utilized it, because this can be an important lesson for other things I'm involved in that can be very helpful.
Yes. So I think I heard a few questions there, but we definitely sought to incorporate individuals with lived experience from the experience of actually having been homeless at least one point, or who are experiencing housing instability and or have a history of brain injury. And on that community work group, we had a few people who fit those categories who we shared the knowledge and information with, and then we actually invited them to be on the grant as consultants, essentially, as part of our community advisory board. And so we talked with them about the aims, and they supplied the letter of support, so they knew what we were doing and they knew what their job was if we got funded. And their job is essentially, as a board, we will meet together to discuss basically every single facet. So even from the interviews. So I'm developing or have developed the interviews now for clients, just a draft, and we'll take it to our advisory board to say, hey, how does this sound? How do we need to reword the interviews so that we can actually do them with the clients that make sense? Same with the focus groups, like how is this being presented and addressed? What kind of recruitment strategies would be the most useful for engaging clients in this work to be participants in the study? So they'll be engaged throughout the entire process. So we'll be meeting once monthly throughout the entire 3-year grant period. So 36 meetings. And we want to, be respectful of their time. So most of their work will be done within the meeting, but there will be times that we'll send them documents in advance to review the best that they're able to, but we'll also do it during the meeting. So they will be engaged every step of the way. And that goes back to what they surprisingly, at the time, the NIH really wanted in the grant was community engaged focus and health equity, which now feels so sad because the term has been removed.
Yes, that was my second question, actually, is what effects that may be having.
Yes.
But I'm more
Okay, well,
interested
that's
in
a
the
good
first
question.
question, in the use of people with lived experience in the messaging, in the reporting, in the representation of your group as a worthwhile undertaking.
Yes, absolutely. Yeah. All of the above. And then to your point, I didn't even address, but I mean, they'll have a say in every little thing that we do. And then when we get to the point of disseminating the results through publications, we'll invite them to be co-authors. We'll invite them to come present with us and all of those types of things too, which is rare. I think people don't do that often, but we're planning to do that as part of our engagement plan.
Yep.
And then I do want to address your one question is, so this work, we got the congratulatory email in September of 24 that we got the grant. Like, we were one of 5 teams nationally who were awarded this grant. We were supposed to have gotten the money in by December. And with the change of administration, we are still waiting on the actual money to come in for this. So we have still been working on the grant, different parts of it, like making sure our advisory board is, ready and convened. We've added additional members to our advisory board. So we have several more members with lived experience. We've engaged new homeless organization leadership and staff. So we've still been working on these aspects. And then, putting together the interview and the focus group drafts so that when it comes time to start meeting, that we will be ready to go. But we are just hopeful that we are not one that gets sliced because of the word equity in the title, essentially.
Okay, thank you.
Again, folks, if you have questions, you can throw them into the chat, or you can unmute and ask them out loud. Kate, I guess my question here in the meantime is, just having been around research for a long time, we don't do this. This is a lot of extra work, right? That I think we've maybe glossed over as a research community in the past. Can you kind of give me a sense, like, I think you kind of made the point of like one of 5 teams to be able to do this kind of work. I mean, how novel is this, and how much of a change in just the way that we do research does this represent?
Oh, that's such a good question. So I think it is very novel in a few ways. And you said one of them already, which is our actual true community engaged approach, not just like performative, but like we're actually going to be bringing the interviews to them. We're actually going to be bringing the surveys to them. They're actually going to be involved in selecting strategies to actually create change that goes into our blueprint. And I think, you see the community engaged participatory approach and all of those things, which are excellent. But when you get to the point of seeing how they're actually operationalized and used, it kind of falls short a little bit throughout the project. So we're fully engaged. So that's number one. In terms of innovation, I think number two is we really don't see a lot of implementation science in brain injury and rehabilitation. I'm one of very few nationally who actually focuses in rehab space with implementation science. There's a handful of others across the country, and it's becoming more used, but it is still not something that's very common. And so actually using implementation science in the field of rehabilitation will hopefully accelerate the use and public health impact of our interventions. So that's another way. And I think too, like when I was doing the write-up of the grant, and there's always a big background section that's kind of like demonstrating why you need to do this, which is based on reading the scientific literature and including all of it. I did a lot of reading. I already acknowledged that homelessness is not my area. And I had to do a lot of reading to figure out what has been done already in brain injury and homelessness. And most of the research that I found was actually out of Canada, some, I think, out of Australia, but mostly Canada. Very little was actually done on those two things in those two conditions in the United States, minus what Caitlin Sinovic, one of our co-investigators, has done, and some of her publications. But very, very little has been done. And I think it's because it is hard to do this type of work in these settings. And I think that has scared researchers away or caused them to say, I'm not going to do this. It takes too long. It's too complicated. The population is too difficult, whatever the word is. And I don't think it's been done at all to the extent that it needs to be done in the US. And that's why I'm still so hopeful that our grant doesn't get cut because of the administration, because it's like finally, like we got funded and we're working on this, we're able to work on it. And then, I hope it continues. And I think we'll find a way we can repurpose the grant. If it doesn't get funded through here, we can put it elsewhere. But we're still waiting.
Ah, yes, that's the other side of research is, well, I've written this 40-page document and I have the team together. Where else can I go? And you have to try and get these shifts done. But hopefully
it
this
was like, yeah,
Go ahead.
so much went into it. I was gonna say it was probably like 240 pages, like at the end of it. And it's okay. It's okay. We will do it one way or another.
There you go. So Sophia had asked in the chat, how does screening for traumatic brain injuries work given the variety of possible symptoms? So maybe this is just a good primer for the different screening tools that we use.
I just want to make sure I understand. So how does screening work? Yeah. Oh, yeah. Okay. So we are using a long-standing validated brain injury screening method that Dr. Corrigan and Dr. Bogner created when they first started at OSU and validated for use. So it is the Ohio State University TBI identification method, OSU TBI ID. It is one of the best methods for eliciting a lifetime history of brain injury. And the way that that's done is through walking the person through a series of events that might have resulted in a brain injury that they may not have known about or may not have put together that caused a brain injury. So I'll ask questions like, have you ever been in like the military? I think that one's obvious. Have you ever had a sports related concussion? That one's obvious. have you ever been in a situation where you've been involved in a fight, or you might have gotten knocked out, or like at a bar or something like that, or in a car crash, or on the playground where you hit your head and you might have been knocked out or blacked out for a period of time. So we'll take the person through these series of questions to help them determine the scenarios that might have resulted in a brain injury, and then asks about altered states of consciousness or loss of consciousness, how long that was for, and when the first injury happened, when the most recent injury happened. And there's also some questions on repetitive head impact through domestic violence and partner violence, or military service, or certain sports like boxing and things like that, that might be, the person might be subject to repeat head injury. So that interview method has been pretty robust and demonstrated to work well by a provider asking the client the questions. But more recently, we have looked at the client taking the questions themselves, and they have about the same level of reliability to do so. So the client can equally take the questions themselves, as long as they're able to read the questions. They might need some help if not, but as long as they can read the questions, they can as accurately answer them without the provider involvement. So that was a long-winded way of answering your question. But I think part of that adaptation is, does it work better for the client to get a paper copy to do it in office, or would they prefer using an iPad or a cell phone or something that we give them to take it online? Do they like that method better? And those are the types of things that we want to figure out in our first aim.
Yes, thank you. I was wondering how that would affect people not finding themselves in an unhoused situation and then realizing how a brain injury would have affected that. And I imagine that would be quite important to know for just your own personal.
Yes. Yeah, so you think like some people, at least, we don't know the true number, but not always get helped after having had a brain injury, because they may not have known it, or they may not have had access to get help after having an injury. And so this helps to identify that. But I think part of what would go, definitely part of what would go into neurologic informed care is the provider being able to be knowledgeable enough to provide education on what it means to have a brain injury and what that looks like. And then, okay, based on some of these difficulties that you're having, or that you're noticing that you're having that are impacting your life, these are some strategies that we will put in place, or accommodations that we will put in place to help you become more successful. So that's the overarching goal, but an educational component is certainly part of it too.
Right. I don't see any other questions at the moment. If anybody has one, feel free to unmute. So another follow-up question that I have is, okay, so we kind of noted, this is novel for many reasons. In your answer, you also hinted that, this is maybe something that's very difficult, or might have scared researchers away in some sense, because we're asking for a lot of comments on things. It might feel like, let's call it inefficient in some ways, right? Because you could get there faster if I just made up the project myself and I said, this is how it's supposed to go. And so I get it out there. So you're taking on a lot of extra steps, which is great, because it's doing it the right way in some sense, right? What do you think will be challenges in getting, all of this work done that then informs a clinical trial or some sort of subsequent work? And what would be the challenges for the people participating from the community?
Great question. So number one, I think the biggest thing is getting through aim one. I think once we get through aim one, we'll be in the clear. And I think the difficulty with that is being able to recruit clients who are actually actively homeless and experiencing not just a brain injury, but like a serious medical issue. So this site that we are partnering with takes in clients who don't have a home, who are discharged from the hospital. So they might have had like a major surgery, and instead of discharging them to the street, they're getting discharged to this place. So you're having a variety of factors that are going on. And so I think being able to approach the client in a way that they feel comfortable and safe to participate in research is going to be extremely important to be getting AIM-1 done. Another part of it that I didn't talk about, and this is a very brief overview of our aims, but what we are also going to do is figure out, because thinking about the population maybe doesn't have that, well, they don't have that permanent residence. They may or may not have a cell phone. So we want to figure out how we can contact them again to find them again after a month, or I think we're doing 2 weeks. And so once we do the interview with them, we're going to ask them, how can we find you again? What's the best method for us to contact you? So 2 weeks after that, we will actually test that method. And if it works, that will be great. They'll get paid for it worked. And then we will know in the future, like, okay, this is what it takes to recruit this population and what we need to do differently. So once we get through AIM-1, I think we'll be really in the clear. But to answer your second question about how we can ensure engagement, appropriate engagement of the stakeholder or the partner group, the community partner group, because the people will have lived experience, actively are homeless, and have brain injury. So that is a lot more challenging. So we are going to use, and people are all over the country too, who are actually in the group. So we are going to use a web-based platform. I have personally met with every single one of our members individually through a web-based platform to make sure that they can log in and like I know who they are. I know that they know how to get in and are enough there at that point in their recovery that they can do all of that. So I've met with them, and if there's still trouble with that, we might have to pair them with a case manager who can help them, get to a place where they can use a computer. Because situations change and it changes quickly. So we might hook them with someone who can actually help them get to that point. So yeah, that's how we're going to ensure engagement, and then making things accessible as best that we are able to. And we also want to really diminish like we are the researcher, you are the subject. I hate the term subject. I do not use that word in my studies. I use participant. I hate the term subject. So they are partners in the research. So what we will try to do to take down some of that power dynamic is we'll give them some opportunity to privately tell us how they might be feeling about how things went in a meeting. We'll do smaller breakout rooms during the meetings too, so they can, work in smaller groups who might feel more comfortable. We have a whole protocol that we actually laid out in the grant that we wrote, specifically how we address all these things. And the reviewers wanted even more, so we came back and gave them even more.
Great.
I think you touched on it. It's great, instead of referring to them as subjects, to refer to them as partners. Indeed is what they are. And
Yes.
key partners at that.
Yeah, definitely. See, Mark says. Yeah.
Yeah, so Mark is sharing his experience. Of course, Mark has spoken in this meeting before. Mark, is always good to have you. And I just actually before I'll just in all honesty, we were talking about how many people are doing this work and the importance of just kind of getting connected to different resources out there, because this is going to be fairly difficult when you think about, when we do mouse work, right, we can order the mouse and we can bring them in, and that might be a true subject, right, not a partner, in the same way. And it's just so much more straightforward. But this has got meaning, if not even more so. And so I think the idea of not just having partners at the table, but also just this sort of worldview of like, where can we recruit from beyond Ohio, or where can we connect with others that are doing this kind of work. So hopefully we can continue to drive those connections as well.
Kata, this is Melody.
Yep.
Since this is being recorded, correct?
Yes.
Okay, then in the interest of accessibility, you should read Mark's comment so that it goes into the recording in case you have an individual that is not able to see.
Sure. So I can read that out. So it says, "Thank you, Kathryn. Such important work. I've been homeless and a BI survivor. This program I work at has a large unhoused population, and we have been screening with OBI SSS, which is a new screening tool, and implementing neuro-informed care." Oh, it keeps moving on me. Has made a huge impact and difference, and then wishes have a good night and best wishes in the research. Um, and this meeting will also be transcribed, so you should be able to see both chat and also um, uh, we can make those text files available to you as well. So last question that I've got here, as I don't see any more. So this is one research project. There's many that are going on. And so I had teed up Dr. Hyzak for sort of just a broader question here of, you know, what do you see in the research overall as it relates to brain injury? You know, you're an up and coming researcher. You got a unique perspective. What do you feel like is kind of things that are out there that are exciting or really interesting to you that we can kind of keep our eyes on?
Oh my goodness. There are so many things. And I know that like you said that you were going to ask this question, but I am going to kind of say the same answer is that there's a much bigger interest in implementation science across researchers in across rehab sites. So spinal injury, stroke, and traumatic brain injury. And my first talk was on implementation science a year and a half ago, and we might be time to revisit that. But basically, it is seeking to figure out how we can get interventions into use, because we have so many that are great that are sitting in the literature not being used at all. So we really need to start thinking about how we can get them into practice. But not only that is we actually still do need quite a lot of interventions, and thinking about how to design for implementation and sustainment while designing the intervention. So stop designing interventions that are so expensive and inaccessible and take 12 months to do. Like, we really need to start thinking about the core functions of the intervention and how we can get it implemented and sustained. If you have a giant intervention that is expensive and complex, your providers are less likely to use it and your survivors are less likely to be able to be engaged in it. So when we start to introduce implementation science very, very early in that intervention development phase, we can start to design much better, that knowing that it's going to be able to be used in the real world. That's
All right. That's great. All right, folks. Well, we're right about our time. So first off, and so Eric says in the chat, well said. I think that's going to resonate with a lot of folks. First off, thank you, Dr. Hyzak, for coming in and speaking with us tonight.
Thank you.
I feel like we'll probably get you back here, hopefully after the grant gets funded and you've got some work done. Maybe we'll get some updates from you. Okay.
Yep.
All right. And then folks, thank you for joining us tonight as well. Again, at the beginning of the chat, if you get a chance to scroll, see some of the information about the upcoming events that we've got going on. So please take a look for those. Now, otherwise, we'll be back in a few weeks for our survivor story. So until then, hope you all have a really good rest of your night, and see you soon. All right. Cheers, everybody.